Hello, I'm Dr. Stephen Patrick, a neonatologist at the Monroe Carroll Junior Children's Hospital at Vanderbilt and director of the Vanderbilt Center for Child Health Policy. Welcome to this four-part series of implementing plans of safe care and family care plans. Over the course of this series, we will examine the role healthcare providers play in a collaborative initiative to support infants and parents affected by prenatal substance exposure. Prenatal substance use is common, affecting 1 in 10 U.S. pregnancies, and it appears the consequences are growing for mothers and infants. Approximately 20% of pregnant persons reported the use of legal and illegal substances in 2020. That's an estimated 760,000 pregnant persons per year in need of screening, assessment, and supportive services. Across the U.S., overdose deaths among pregnant people are reaching record levels, and infants are entering foster care at rates faster than any other population of children, most due to parental substance use. Often, prenatal substance use goes undetected. The Substance Abuse and Mental Health Administration estimates that only about 5% of substance use is detected during the prenatal period. But sometimes, like in the case of newborn drug withdrawal, there are clinical signs that become apparent shortly after birth. In other cases, like alcohol, which is the leading cause of preventable developmental delay in children, it can be completely silent. Prenatal exposure to opioids may result in neonatal opioid withdrawal syndrome, or NOWS. Infants experiencing NOWS, also called neonatal abstinence syndrome, may exhibit a variety of clinical signs, including feeding problems, irritability, increased muscle tone, and tremors. A recent U.S. study found the rate of mothers with opioid-related diagnoses at the time of delivery jumped from 3.5 per 1,000 births in 2010 to 8.2 in 2017, an increase of 131%. The study also found an increase in the number of infants with a NOWS diagnosis, increasing from 4.0 per 1,000 births to 7.3 per 1,000 births, representing an increase of 82%. The study is based on data from the Healthcare Cost Utilization Project's National Inpatient Sample and State Inpatient Databases. The HCUP databases include all-payer hospital discharge data from hospitals in 47 states and the District of Columbia. These data reflect the critical need to not only treat the infant symptoms, but to provide treatment and supports to pregnant and parenting persons with substance use disorders. Plans of safe care, or family care plans as some jurisdictions call them, offer the opportunity for care coordination to meet the needs of these families and their parents or caregivers. These care plans seek to improve the health, safety, and well-being of infants born with and identified as being affected by substance use or withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder. And this four-part module series covers several areas, including the Child Abuse Prevention and Treatment Act as it relates to infants affected by prenatal substance exposure, determining who needs a plan of safe care and how notifications differ from Child Protective Services reports, collaborating with community partners and implementing plans of safe care, and finally, developing and using plans of safe care as a care coordination process from pregnancy to birth and infancy. Each module contains an overview and learning objectives, subject matter content, on-the-ground examples, and questions healthcare providers can ask collaborative teams engaged in this work. I'm grateful to the National Center on Substance Abuse and Child Welfare and the Vermont Oxford Network for producing this series. If you'd like more information about the National Center or Plans of Safe Care, visit their website at ncsacw.acf.hhs.gov. Thank you.